we are going into a HIPE. So these are questions that you submitted. The community, you submitted them when you registered. You guys emailed them us. So email them to us. Unfortunately, because we are going to do a speed round for Unicure News at the end, a lot of your questions unfortunately won't be answered this time. I'm sorry, but let's jump in, and we tried to do our best. We'll try to get as many answered in 45 minutes.
Great. First up, Dr. Furr Stimming. Often I hear that therapies, example PTOTST, are discontinued after a few sessions. Different people with different insurances. Why? If a doctor feels they are helpful, why do we have to jump through hoops to continue them regularly? Disrupting their routine sometimes causes them not to want to restart.
It's such an incredibly insightful and important question, and one that not only our families are asking, but we as the physicians and clinicians are asking and are frustrated about. So we can't underestimate the importance of PT, physical therapy, OT, occupational therapy, and ST, speech therapy, in helping our patients with the symptoms of HD. They're really effective for treating the symptoms of HD. But as you mentioned, often we'll order PT and it may or may not get covered. And if it gets covered, it's only covered for a short period of time. And then there's this sort of period where we have to wait for folks to reset and reinitiate therapy. And so the short answer is it's complicated. So many insurers will cover what's called rehabilitative or restorative therapy. So which works if you think about maybe you break a bone, right? And you need to work with a physical therapist to get stronger. Then you work on getting stronger, you've healed, you've improved, and you're back to your baseline. That's restorative or rehabilitative therapy, and that makes sense for many conditions. But for chronic progressive neurodegenerative diseases, what we need is maintenance therapy. We know that these conditions, in this case, HD, we know HD is progressive. We know the symptoms, unfortunately, will worsen over time, and hopefully with the exciting research underway, that will change over time. But for now, we know that our patients need maintenance therapy. We want to slow the progression of disease or minimize the risk of complications. And so actually, we've made some progress. In 2013, there was a legal settlement, it was called Jimmo versus Sebelius, that clarified that Medicare must cover maintenance therapy if, in fact, this maintenance therapy helps slow decline. So we not only to cover rehabilitative or restorative therapy, but to help maintain an individual's function and to slow decline. So this was a big win back in 2013, but despite this, the implementation has been inconsistent. And so more often than not, the commercial insurance providers or Medicare will only provide restorative therapy. So what I think is important for all of you that are listening to know is that, again, there was this case, and this has been maintenance therapy has been approved for individuals with chronic conditions. It's just the implementation is not as easy as it should be. So what we can do as the clinicians and as a community, what you can do as a patient or a patient's care provider is to really try to advocate for maintenance therapy. So ask your provider when your provider says, you know what, I think your loved one needs some physical therapy, speech or occupational therapy, to document that he or she needs maintenance therapy to prevent decline, to maintain mobility and or preserve swallowing, safe swallowing, for example. You'll likely have to appeal the denial for maintenance therapy, but if your physician has to appeal this decision, then you can ask your physician to reference the Jimmo versus Sebelius case. That might help with the documentation. We can all continue to advocate for maintenance therapy for all, because again, it's incredibly important that we have not therapy that's intermittent, but therapy that is continuous, that maintains function. So I applaud the individual that asked this question, because it is, like I said, a really insightful and important question. And the bad news is it's harder than it should be to get maintenance therapy approved, but the good news is it's possible, and that the precedence has been set. So we just have to advocate, use our voices in trying to get maintenance therapy approved for our patients.
I wrote that one down because we struggled with that too. And when the question came in, I'm like, oh my gosh, we've heard this on support group. It's repetitive. And I'm like, Okay, maintenance versus restorative. That's
Yeah.
in there now.
Yes.
Okay, Dr. Sung, what trials are enrolling right now?
I assume the question is really focused on treatment trials. And unfortunately, right now, for treatment or interventional trials where you could receive some type of therapy, there are none that are currently enrolling. Although Spark may be taking a few patients, but other than that, not really any of them are enrolling right now. What I tell people to do is do Enroll HD. Enroll HD is enrolling, and it will set you up so that I literally get an email printout every time a new study is starting. Like, here, dear Dr. Sung, here's your 12 patients from Enroll that qualify for the upcoming study. So that's the best way to be ready. There are multiple that will be launching in 2026. I've already signed contracts and all these kinds of things getting ready. So Wave will be ready to start in 26. Novartis will be ready to start in 26. Prolenia is going to do another trial there, likely it's going to start in 26. There's early to mid 26 is what I would shoot for, and there's going to be a bunch of trials starting.
Yes, thank you.
Dr. Furr Stimming, do gene therapies affect the ability to have children? Meaning, if I were to receive a gene therapy, would this change my child's risk for HD, or would it affect my child's health in any way?
That is an excellent question. Thank you for asking that question. The short answer is no. So somatic gene therapy, and I defined earlier somatic instability, somatic expansion, somatic gene therapy, which is really what the current therapies are in the land of HD, only target certain cells or tissues in your body, and for example, nerve cells in the brain. But these treatments do not change your DNA in your sperm or egg, or otherwise known as your germline. So this means that your children will inherit your unmodified genes. So their genetic risk for HD is unchanged. So the gene therapy may help you, but it won't affect the genes that you pass on to your offspring. By contrast to somatic gene therapy, germline gene therapy would be heritable and would change your children's genetics. But this is not currently being studied in humans, obviously for ethical restrictions and considerations. If you have HD, and you undergo one of these therapies and you're participating in one of these trials, your children's or your offspring's risk for HD would remain the same. And in summary, somatic gene therapies and the kind that, like I said, are used in the land of HD research today do not change your child's risk for HD.
Thank you. And I actually want to, just a quick question. We've been speaking to the FDA a lot lately, and I know I spoke to the FDA and not a public meeting, and they were talking about family planning with me and wanted to know. And then Jamie and Lauren went on the CBER meeting, patient listening session. I did the first one, they did the second one, and they were they made a really amazing question to Jamie Jamie did an amazing answer. The FDA asked about family planning and having children when it came to gene therapy. And I found that interesting. Jamie had an amazing response of, there's other ways to have children. There's other ways to make families. I'm fighting HD. But I wonder, why do they keep asking that? Why does the FDA keep asking about family planning and children when it comes, and specifically CBER?
I think they don't understand. I think that's an important distinction. What Dr. Furr Stimming said is correct, but even Unicure, which is a gene therapy, AMT-130, which is a Unicure's gene therapy, even in the brain cells, it doesn't change your genetics. It just inserts a little stretch of DNA that does something, but it doesn't change your DNA. The only thing that would actually change your DNA would be something like CRISPR, and we're not there yet in HD. So
I wonder if they're asking that because they're preparing for that. And
yeah,
they're kind of getting
maybe.
a feel of our community and how we feel about that.
Yeah.
Thank you so
Yeah,
much.
probably so. Under the umbrella of gene therapy. Yeah.
Sure. Okay, so Dr. Sung, and maybe you can help me, because we did these as we wrote them as they were submitted. So maybe we can break this down a little. How can we learn our biomarkers showing HD progression, and why aren't they used in clinicals, at least to assist in denied psychiatric behaviors?
It's a great question. So the things that we use to look at a biomarker, Obviously, your HD CAG repeat number in the blood cells, if we check it over time, it doesn't change. So that can't, what we need for a biomarker is something that changes over time in HD to show progression, just like this question is asking. So we've talked about that in clinical trials. So NFL is used that way, volumetric MRI is used that way, things like that. The short answer for why don't we use them in clinicals is these tests are very hard to do and are not commercially available. There is no NFL is actually really hard to test for because of the stringent lab requirements and things like that. Most labs cannot do it. So you can't order an NFL level on anybody currently. Like no, there's no commercial lab that offers that test. Similarly with volumetric MRI, that's actually my answer when people have asked, can I get my striatal volume so I can find out now if Unicure opens back up that I could know my brain volume to get into that study or know where I stand, things like that. And the answer is there is no way to get volumetric MRI. If I order that MRI and say, please do volumetric analysis on the striatum on my HD patient as an add-on, my radiologist would be like, I don't know what you're talking about. We don't have the software to do that. So it's a particular, like these are just unfortunately not tests that are clinically available yet. And there's a lot of things that tests have to go to become clinically available. I wish we had it. It would be helpful in a lot of ways, but there are no biomarkers that are available for clinical use in the United States so far.
Thank you. Dr. Furr Stimming, why is it that two people of the same sex, same age, same stress levels and lifestyles with the same CAG have different lifespans?
Yeah, another fantastic question, and certainly an area of interest in the land of HD research. But the good news is we've learned a bit more here more recently, and as to why we see this variation, not only in kind of the duration of symptoms and rate of progression, but also age of onset. So as we've talked about already, the number of CAG repeats is great. It helps us in determining whether or not an individual will live with the symptoms of Huntington's disease throughout their life. We know that the number of CAG repeats is inversely correlated with the age of onset of symptoms, but we know this is not the end of the story. So this only accounts for about 60 to 70% of the variance as far as age of onset. Not so much for rate of progression, but a little bit. But this means that up to 30 or 40% of the difference actually comes from other factors. And so we think that these other factors are probably genetic. And as I like to say, it's all in the genes, it's all in the Gloria Vanderbilt, but it's genetic and they're probably environmental influences as well. So we know that even individuals with the exact same CAG repeat count can have very different trajectories because, again, the CAG number is not a perfect predictor. It's more of a range kind of indicator, if you will. So within the past decade, through beautiful work that's been done by our friends and colleagues and by the wonderful individuals that contributed to research and donated their samples through the GEM HD Consortium, we have identified modifier genes that seem to influence the age of onset and rate of progression. And so these are, we've alluded to these earlier and you've heard about these, I'm sure, along the way, but DNA repair genes or mismatch repair genes. And there are some that you may have heard about: MSH3, FAN1, PMS1, just to name a few. And these genes, we think, affect how unstable the CAG repeats are and influence to some degree the somatic expansion that we talked about earlier today. So we know that even though two people with 42 CAG repeats, for example, in a blood test might have very different repeat links in their brain cells. So not that again, peripherally, their blood test will show 42 repeats likely throughout their life, but we don't know exactly what's happening in the cells in their brain, but we suspect that there may be differences in the number of repeats over time. And this can sometimes explain why the symptom onset, the timing of symptom onset is different and rate of progression is different, despite two individuals having the same number of repeats. So there's more to the story is the bottom line from a genetics perspective. And the great news is, as I mentioned earlier, when talking about somatic instability and somatic expansion, is that we now have targets, additional therapeutic targets. And some of these compounds, as I mentioned, that are being studied in potentially slowing disease progression are now targeting some of these mismatch repair genes. So it's a really exciting time. But I also want to mention just the influence that environment, diet, and lifestyle can have. So we know that there's a lot in this world that we can't control. And then in those with HD, it can often feel like there are limitations and there's not enough that we can do. But I like to just talk to my patients regularly about getting back to the basics and controlling the things we can control. And so we can, to some degree, control not completely our environment, but we can at least make some lifestyle modifications. We can control our diet. We can control the amount of exercise we get or we don't get. We can, to some degree, control or try to control our sleep quality and quantity. And so we have some evidence that actually diet and lifestyle and environment may also influence the age of onset and rate of progression. And so we can't underestimate the importance of a healthy diet, a Mediterranean-like diet, exercise, so aerobic exercise, when and if we can get it, targeting about 150 minutes per week, socialization, cognitive exercise and cognitive exercises. All these things are incredibly important for all of us, by the way. And I wish I could say I practice what I preach to my patients all the time, but I'm working on it. But really important for all of us, but important in determining when individuals become symptomatic and what the rate of progression might be. So it's really a combination of factors, like I said, genetic and environmental, most importantly, that influences not only when individuals become symptomatic, but what their rate of progression might look like.
Thank you. Dr. Sung, when do we really know when it is a symptom or a personality trait? Aggression has been present for years without much else as far as symptoms. The aggression seems to increase when tired.
All right, so first, all HD symptoms will tend to increase when tired, right? Because your brain's ability to suppress the things that you don't want to be doing, or it just gets weaker when you get tired. And so all the symptoms of HD, chorea is worse when you get tired, right? So all those things will come out more. As far as when is it a symptom of the HD and when is it a personality trait, it can be really hard to distinguish. But I generally say that if there's a personality trait that's there, HD can exaggerate it, right? When it comes to aggression, my patients will say, yeah, they've always been spicy, but now that they've become symptomatic with their HD, it's just more, right? Or if they've always been really laid back, then maybe that's a patient that has much more apathy than aggression, right? So it tends to exaggerate underlying personality things that were already there. So our more passive patients tend to be more apathetic as they get in their disease. Our more spicy patients, personality wise, will tend to have a little bit more aggression as they go through it. But as far as what is what or how much of it is their innate selves and how much is the HD, there's no way to totally know. But I would just say if there's a symptom that is impacting you greatly as the caregiver, address it with your clinical team. And there's often not just pills to throw at it, but there's adaptive strategies. This is the kind of stuff that is talked about in support groups all the time too. So reach out. Everybody's got their little tips and tricks on how to deal with it and how to address it.
And Dr. Sung, real quick, also we said sleep and tired, but I also saw with my husband, whenever there was something that was like alcohol, things like
Yeah.
seemed to like really that aggression seemed to come out or something like that was not, and he was the laid back one for sure. But when he drank, it seemed like some of these symptoms like came up
It flipped
before
around. Yeah.
we even knew about HD. It was like shocking.
Yeah. Yeah, anything going on in the body, both either emotionally or physically, can impact that. So they'll have an exaggerated response to alcohol, tobacco, any substances, things like that. But I have patients that every time they get hungry, all their stuff is coming out. I'm sure many of you notice, like during mealtime, movements come out, behaviors come out, things like that. So it's a lot of these things. It's just the HD is just very sensitive to everything going on in the rest of the body and the world.
Thank you. Dr. Furr Stimming, are there any studies focused on digestion or the impact that chorea has on digestion?
Yeah, that's a great question and coincidental because we're actually going to, in the process of initiating a study in our clinic to try to determine the impact that medications, common medications that we use to treat chorea, the impact that they have on swallowing function. We know that sometimes, we talked earlier, defined dysphagia, which is difficulty with swallowing, that can be part of Huntington's disease, particularly as folks live longer with Huntington's disease and the disease is more advanced. But we know that swallowing can be impaired for many different reasons. And so sometimes if there's significant oral, for example, oral buccal lingual in the mouth and the tongue is moving, that can negatively impact an individual's ability to swallow. And so if we're able to effectively suppress the chorea with medicines, then the swallowing may improve. But then there's some reports, and we've heard from our patients that maybe sometimes in starting medicines to treat chorea that their swallowing function actually worsens. And is it because of the medication? Is it because it's just part of HD? We don't really know. So we are hoping to learn more about the impact that the common medicines that we use, whether it's the VMAT2 inhibitors or the neuroleptics or antipsychotics, the common medicines that we use to suppress chorea, help or hurt in the realm of swallowing. We're also doing a study, an observational study, so just collecting data at our center to learn more about autonomic dysfunction in HD. And so one of the symptoms of autonomic dysfunction can be bowel and bladder symptoms, or a couple of the symptoms, I should say. But in the realm of digestion, we know that there can be various symptoms that individuals can experience when it comes to their GI function. So they can have diarrhea, they can have constipation, they can have a little bit of both, and it's consistently inconsistent. And so we're really trying to understand how often our patients are experiencing autonomic dysfunction, and in this case, and related to this question, how this impacts digestion in HD, and really after we can define how often it occurs, then more importantly, what can we do to address these symptoms?
Dr. Sung, do you recommend that your patients enroll in the first open clinical trial that they qualify for? If they are willing to do trials, how do you determine which one is best for your patients?
Yeah, this is a complex question. I think as someone who does the trials and then takes care of patients every day, I really take on that responsibility seriously on guiding my patients to which study may be best for them. So that's definitely a discussion to have with your care provider, with your whole family. And some people are like, oh, isn't that heavy? What if you guide them to do this study and that study fails, and they could have done another study and that study succeeds? Isn't that you're taking that on? And for me, it's like I take that on as part of everything that I do in taking care of this person with HD. And I wouldn't want anybody else to guide them to make that decision for my patient than me. So I take that on seriously. But then the first part of the question, generally, do I recommend the first open trial that they qualify for? Generally, the answer is yes, because it's so hard to predict the future. And if you hold out and say, I'm not going to do this trial, I'm going to wait for this trial, we've seen it time and time again, like waiting for a trial, that trial may never come, or that trial may be very delayed. So very often you can, and our windows to participate trials are so narrow. Very often you can do the trial that's in front of you, finish it, and then still go for something else down the road. We may have some time next year where there's multiple trials opening at the same time, and that will be a little bit of a discussion. But for the most part, studies have rolled out kind of one at a time and not had a ton of immediate competition. So that's my thought on that.
Yeah, thank you. Dr. Furr Stimming, with a couple of family members, I have noticed really wide eyes when they start to progress. Is this common, and why?
Yeah, great question. So this is not terribly uncommon as HD progresses, and it's mostly because of the disturbance of the area in the brain, the basal ganglia, the dysfunction of the basal ganglia that negatively impacts coordination of movement, speed of movement. We talked a little bit about the hyperkinetic movements that are common in HD, and then in parallel to having hyperkinetic movements, individuals can also have hypokinetic movements, or not enough movements, or slow movements, as we define bradykinesia. And so with the wide-eyed stare, what often will happen is that there's activity of the frontalis, the forehead muscle, that can contract, whether it's chorea or dystonia, which is similar to chorea, but it's a slower, more sustained movement. So there can be contraction of that frontalis muscle. There can also be delayed and slowing of the muscles that are used to close the eyes and to blink. So there can be slowing of the blinking that occurs that naturally, but it's not as natural in someone with more advanced HD. And so because, again, of that frontalis contraction and the delayed blinking, we can see what appears to be a wide-eyed kind of staring in individuals with more advanced HD.
Dr. Sung, why does my husband hold his breath? Then he will gasp for air and he doesn't even realize he's doing it.
This really gets to what Dr. Furr Stimming was saying earlier about autonomic dysfunction. So autonomic dysfunction, so I think about it as automatic things. So the things that used to be automatic for our HD loved ones become less automatic. So that can be everything from blood pressure control or temperature regulation to breathing, like in this case. So the things that you normally don't have to think about it's just not quite as automatic anymore. Now the brain will kick in if you stop breathing. Eventually you'll need that oxygen and it'll gasp for air. But you normally don't have to think about breathing. You normally don't have to think about controlling your blood pressure or these kinds of things. But those automatic functions of the body tend to get messed up in HD over time.
Okay, Dr. Furr Stimming. When someone is on a VMAT2 inhibitor, has that shown to increase or decrease cognitive function?
Yeah, that's an interesting question. And the short answer is we really think that let me first define the VMAT2 inhibitors just in case. Thank you to the individual that asked the question. But the VMAT2 inhibitors are medications like tetrabenazine, deutetrabenazine, otherwise known as Austedo, and valbenazine, otherwise known as Ingrezza. And these are the three FDA-approved medicines that can be used to treat chorea in HD, or the most common involuntary movement in HD. And so the question was, do these medications negatively impact or positively impact cognitive function? And at the end of the day, we don't think that they really have a significant impact on cognition in HD. They really are medicines, as I said, indicated for chorea, for the motor symptoms of HD. We're certainly interested in looking at the impact that these medicines can have on the non-motor symptoms, and the symptoms that we can't necessarily see, and cognition would fall under that umbrella. But we don't have significant evidence to support that the VMAT2 inhibitors impact cognition for better or for worse. We do know that the VMAT2 inhibitors can potentially worsen mood, and so that's something that we always talk to our patients about, the black box warning surrounding the VMAT2 inhibitors of potentially increasing depression and or suicidality. However, I suspect, I know I've seen this, I suspect Dr. Sung has seen this as well. Often when we start a VMAT2 inhibitor to treat chorea, my patients will return to clinic and say that their mood is actually better because their chorea is better controlled. So the VMAT2 inhibitors can impact mood positively and potentially negatively, but not so much in the realm of cognition.
Thank you. Okay, so we have all heard the news about Unicure. So if we can move on to a couple questions. When we first actually started this, we put out the registration and we let people ask questions. The amount of questions we got from the community about AMT 130, Unicure, we couldn't even answer all of them in a HIPE session. And then we had all these questions ready to go, and then all of them now can't be answered. So we took all those questions that we already gave to Victor and Erin, and we said, okay, we know that we can't answer these now. So what can we answer? So the next couple minutes, let's say what we can answer. what you guys can possibly try to answer. So we hear like RMAT, we hear breakthrough drug, we hear all these pathways, and then we see this data and everything looks so good and everyone's ready to go. We're so excited. The community goes crazy. They are so excited, finally, real hope. And then we get the news. So why don't we start? You guys can just go back, Victor, maybe start. What news did we get? And what does this announcement actually mean?
Yeah, so obviously we're all flying on high with the positive top-line data release announcement that uniQure made end of September. And then they were meeting with FDA for what we call a pre-BLA submission meeting that was already planned. And that meeting happened last week. And then at that meeting, unexpectedly, the FDA said, actually, we don't like the data enough, and we're not going to let you file. And there's reasons behind that, but the bottom line of what that announcement means is that even though this data was positive, it's not going to even have its day in court unless something changes. But the FDA is saying, we're not even going to let you submit this data for us to look at. We don't want to accept it as a submission. And that the reasoning that they gave was because the study, when it started, was not designed as what we call a registrational study. It was not designed to be the one to prove that it works and submit for approval. But along the way, as the study was going on, there were positive things that were coming out of it in what we call interim data analyses, such that the old FDA said, this is good enough that we're going to give you breakthrough designation. So breakthrough designation means that even though you didn't set out to say this is going to be your trial that you submit to FDA, you're having such good results that we're going to let you submit it as trial to let us consider for approval or not. But there's new leadership at FDA, and they've now decided that this data is not good enough. What that means is that there's more things that we can do. And I think even uniQure has said that the data that we have has not proven that the drug works, but accelerated approval is a pathway that we could get the drug out there to patients and then collect more data and show does it work or not. But that pathway is now closed. They're not going to even accept it. They won't even look at the data, right? That's what this announcement means. It does give us an opportunity, and I'm sure, Katie, you'll talk about that. We can push back on FDA. This decision is not totally final, and there has been a precedent in other diseases where they've said this. That's happened this year, where they've done the same thing, walked back their offer to allow a submission, and with pressure from the community, both patients and clinicians said, okay, never mind. We said we weren't going to take the application. Okay, you guys really want it, then we'll take the application now. So but that's where we are.
Thank you. Dr. Stimming, anything to add?
No, I completely agree with everything that Dr. Sung has said. It feels deflating and defeating for the entire HD community, but we can't take away the data, the fact that the data was positive, right? We still hold on to. And while this doesn't mean that the data that was presented, that top line data, is any different, it just means that the timeline is likely going to be different than anticipated. And so it's, like I said, it's disappointing. It's just overall, we're feeling defeated, deflated, because the news was so exciting. But again, we had to advocate, use our voices, and again, focus on the fact that the results that were presented were positive. We all acknowledge there are limitations. We acknowledge that this is a teeny tiny study, and the study is ongoing, and all the potential limitations and inherent limitations when it comes to tiny studies and rare diseases. We know this, we acknowledge this, but we have to collectively use our voices to advocate, as you all have been doing and will continue to do, to move these therapies forward. Just to be, and really in this case, as Dr. Sung said, this is just to evaluate the data. We need, like he said, our day in court to fully evaluate the data. This is not even to say yes or no as far as approval, accelerated approval. It's just to evaluate all the findings from the study.
And it's interesting because this is our like first gene therapy, right? And gone this far. So what do you actually think could possibly happen with gene therapy as a whole in the HD space because of this?
Yeah, if we don't successfully move the FDA back on this decision, what the concerning thing would be that for all gene therapies coming down the pipe, that they're going to have to go to these big phase 3 trials with sham or fake surgery component and have large numbers of patients. It's just going to make it the bar is going to be a lot higher. And there is the reality of expense. So gene therapy trials are much more expensive to do than pill trials or even ASO trials. And it begs the question, would these big pharma companies want to spend? It already takes $1 billion or so to get a drug to approval now. But a gene therapy trial, if they're going to require these big phase 3 trials and not allow accelerated approval off of a phase 2 trial, that's going to make the expense even higher, like $3, $4, $5 billion to get a drug through. And then does that mean that pharma is going to say, forget it, that's too expensive? So I don't know. We still remain hopeful that we can push back on these things and keep the door open, because I still think gene therapy, while we understand it wouldn't be for everyone, even if this got approved, it wouldn't be for everyone and not everybody would want it. But more options is better for our community.
Absolutely. We live in with HD every single day. And so HD is our focus and our everything. But let me tell my community, we aren't the only disease they've done this to. We just heard the ataxia. You can go look at the response of the FAS and we can put that up. Arlene, our social media manager, let's throw up those articles that are on our social media and our Facebook. We are not alone in this. This is something that is going on with other diseases as well. And it is frustrating for other disease communities as well. So is it time to stand up? Because I want you to know it's not a target on HD. It's, in my mind, an FDA problem that needs to be looked at. So we have the announcement, the ataxia. Obviously, I'm not even going to try to say the drug because it's what?
Yeah.
Dr. Sam?
It's called troriluzole. It's all the R's and L's make it really hard to say.
Yeah, it's like it seems like it's the same thing that they're doing to that community and others right now. So if that's the case and we continue on this and we don't fight back and talk to the FDA about how we're feeling about this, what do you think this is going to mean for future trials just in general?
Yeah, so the spinocerebellar ataxia, which is what this troriluzole drug is for, is actually pretty similar in a lot of ways to HD in that it's a genetic condition and it's very slowly progressive over many years. And I think that's the thing that we about is that in these diseases that are very slowly progressive and we have to do very long trials, it's hard to ask patients to stay blinded that they might have had placebo for 3, 4, 5 years. Really hard to do. And it's nice to have an option that they could compare to control groups that are really strong in Enroll HD. Some of the ataxia, they don't have a total equivalent of Enroll HD for their study. So some of that criticism might be that their control group is not as good as ours, but still having the option of comparing to an external control instead of having to keep people blinded is an important option that we'd like to keep open for us in HD trials going forward, because it's hard.
We deserve to keep it open. We've been told for
Yeah.
years. I started Enroll HD with my husband years and years ago. My husband's been gone 6 years. We were told that if we got in these natural history studies, I put my children in natural history studies. We were told if we do this, that it will help us develop and expedite drug development. We've been made a promise, and the FDA has been on board with natural history studies and using these external controls. So in my mind, the only difference is why now change this? When we have put the HD communities put our time, are going to the clinic, finding daycare for our children, doing all of this because we were told that this was going to help expedite drug development. Okay, so I'm going to breathe because I'm going to be probably having to breathe a lot. Dr. Stimming, do you have anything that you would like to add to that?
No, I don't think so. I want to commend you and all of our HD community members that have participated in these natural history trials. And as you said, Katie, it's a lot of work, right? You have to go to clinic, you have to get your blood drawn, you have to take time out of work or school. And so we're just so grateful. And please know that all of the time and effort that you've committed to these studies matters. And we will make a difference, and we will succeed. So we have to focus on the positive, which is the fact that we are heading in the right direction. We've learned so much, not only from the natural history studies, but from the interventional trials. And the data from Unicure, again, there are limitations, but is suggesting that we're on the right track. So we just collectively need to use, as I said earlier, and as you've been shouting from the rooftops, use our voices. HD is a rare disease. As we know, most folks say, oh, I've never heard of HD. Nobody knows HD. But as we continue, as you are all doing, we continue to use our voices to raise awareness and to educate the community, educate the FDA on what HD is all about. We will make progress. There's no other option.
Yeah.
Right.
And Katie, can I add, like, the tone that, one of the things that I was sensing from what you're saying is something that I've heard from both clinicians and patients too, is gosh, if, like you were saying, the FDA promised these things, they accepted these things, and now they're walking back these things. The only things that have changed is political climates, things like that. And I've heard some people say, then do we just need to give up and wait 2.5 more years until the possibility of a new administration comes along? We can't. We don't have 2.5 years to wait for our community. We can't give up, right? So we have to fight and we have to push back. And I think the nice thing is that there is a precedent that when the community stands up and says, no, don't forget about us, hear us, that they actually do listen.